Hey, my name is Gerard Silvestri. I'm a professor of medicine and the Hillenbrand Professor of Thoracic Oncology at the Medical University of South Carolina. I really would like to welcome everyone for joining us this evening. I think we have a really good program here for you. We'll be talking about EBUS and the collection of tissue for biomarker analysis. We have two experts on the line. And we are going to be having some questions and answers at the end after Dr. Machuzak gives his talk. And we would love for you to use the chat box along the way. I'd like to thank Chess for putting on this webinar, as well as AstraZeneca for supporting this. And so what I'd like to do is have Dr. Machuzak put up his slides for us.
Good.
And I'm sure that more people will be joining as time goes on. So during the webinar, after Dr. Machuzak speaks, I might just welcome everyone again to use the chat bar. And again, this is going to be the role of the pulmonologist in tissue acquisition, specimen handling, and molecular testing in late-stage non-small cell lung cancer. And if you could go to the next slide for me, Mike. And I'd like to welcome our panelists. The first is Michael Machuzak, who's an amazing interventional pulmonologist. I've probably known for more than 15 years and watched him teach learner after learner after learner how to do appropriate bronchoscopy. He's a wonderful teacher. He's also the medical director of major airway diseases at the Cleveland Clinic in Cleveland, Ohio. And thank you so much, Michael, for joining me.
Yeah.
I'm also going to welcome Jennifer Brainard, who's a staff pathologist and vice chair of pathology operations, also at the Cleveland Clinic. She works closely with Dr. Machuzak on preparing specimens for pathologic analysis. And so I really think this combination of having a pathologist and a pulmonologist who work in the same institution talk to us about how that combination of people can lead to better diagnosis, staging, and treatment options for our patients with lung cancer. And now I'm going to let Dr. Machuzak take over, and he's going to provide us with, I'm sure, a wonderful talk. Thank you again, Michael.
Thanks, Gerard. Thanks for the intro. First, I want to thank Gerard. I want to thank Chess, AstraZeneca, and also especially Dr. Brainard. Jennifer Brainard has been absolutely instrumental to what we do here as far as our EBUS and lung cancer goes. So you'll get a chance to hear from her at the end, but please stick around because it'll be an absolute joy for you. So as Gerard said, I'm going to talk about the role of the pulmonologist in tissue acquisition, specimen handling, molecular testing in late-stage non-small cell lung cancer. So as an intro, I'm going to talk a little bit about what role we as pulmonologists play. Also, how does EBUS play a role in all this? We're going to talk about driver mutations because I know when some of this first came out, myself and a lot of our fellows don't really know what they are. How do we test for them? And then there's this alphabet soup of what they are. So hopefully we'll have a little more understanding between those. And then also the PD-1, PD-L1, PD-L2 interaction, and talk a little bit about what role that plays in lung cancer, prognostication and treatment, and what the differences are. So focus for right now is going to be on what role does a pulmonologist play in non-small cell. So our primary role is prompt diagnosis and staging, because that leads to treatment. We know early intervention improves survival, and lung cancer has the highest mortality rate of any cancer in the world. Somewhere between 1.4 and 1.6 million deaths worldwide are going to happen this year. It's the leading cause of cancer death in the United States. And if you take the next 4 cancers combined, lung cancer still kills more each year. So it is a big deal in our world. So how do we play a role? We play a role in bronchoscopy, and in particular, endobronchial ultrasound, among others. So we're going to focus on EBUS and tissue acquisition there. We want to work on how we can all adopt a diagnostic procedure like EBUS, understanding that tissue is essential for diagnosis, for staging, but not just getting tissue, making sure we got adequate specimens, and that will guide our targeted, our personalized therapies. So as pulmonologists, we all need to be familiar with changes, advances, and as current as possible in molecular markers. There's been a paradigm shift. We used to have this homogeneous therapy. It was just basically chemotherapy that would kill cells. Now, treatment and course is dependent on molecular markers more than anything else. And potentially every decision we make about treatment is going to be based on tissue that we get at that diagnosis and staging. So there's a huge importance on this tissue, but not just on getting the tissue and also how we handle it. Our sample size has gotten smaller, but the amount of information we want to get from that has increased. So we want to optimize our specimen collection, we want to optimize our processing, and ensure we've got quality and quantity to get the answers we need to take care of our patients. As all of this has evolved, so has the role of EBUS. In 2007, it was suggested as a reasonable approach to get tissue for staging. In the guidelines of which Dr. Silvestri was the lead author on, in 2003, it was now said that a needle technique is recommended over surgical staging as the best first test. So quite a change in just a few years. And that has been true moving forward. And why is that? It's because EBUS is pretty good. It's less invasive and at least as accurate as mediastinoscopy. It's got a great sensitivity. It's got a high specificity accuracy. But more importantly, it's been reliable and reproducible over the past 15 years of my career as intending. And you can see the chart on the right here. We now have thousands of patients. This is from 2013, so we've gone way past these numbers, but sensitivity, specificity, and the usefulness of EBUS has continued to be consistent and continue to be reliable. So when do we perform EBUS-TBNA? There's two general reasons. If we're looking at it for staging, or we're looking at it to gain tissue in a non-staging situation. So if we're talking about staging, it's patients that have an intermediate suspicion for having N2 or N3 involvement, at least stage 3 disease. And those are patients that have a central lesion. So the tumor is close to the main airways, not a peripheral lesion. If we have evidence of N1 or hilar node involvement, it's enlarged or it's avid on a PET scan. Or if the peripheral lesion is a clinical T2 or bigger, meaning more than 3 centimeters in size. We're very often asked to get tissue in a non-staging situation as well. So we need more tissue because, well, we're not sure about the diagnosis, or we need molecular markers to treat this patient. Now, when we talk about doing EBUS, there's a lot of questions that I'll get in some of these courses. So I put a few of them together here. So the first is, what kind of sedation do we use? What kind of sedation is best? There's no evidence that GA versus moderate has a difference in yield. Now, I want to put an asterisk on that. It's one study done at one center, and that was a phenomenal bronchoscopist at a well-experienced center. So keep that in mind. Does the type of airway matter? Is it an oral airway? Is it an LMA? Is it an ET2? Again, no evidence that one is better than the other, but if you're using an ET2, keep in mind the tube has got to sit high. Otherwise, you're going to block access to the high paratracheal, 2R and 2L nodes. Minimum size is an 8. It's got to be a big tube. And then you also want to think about protecting your bronchoscope. Now, when we're talking about staging, we want to make sure we do it in a way that makes the most sense. So it's got to be contralateral to ipsilateral. If I've got a right lower lobe lesion, I'm starting on the left side, working to the right. All nodes bigger than 5 millimeters in size. Now, there's some discussion now about are there some ultrasound features we can use to possibly not biopsy lesions, and that's the Canadian lymph node scoring system brought around by Kazu Yasufuku. I don't want to go into too much detail on that in the talk now, but if you have questions about it later, I'm happy to come back and talk about it. But basically, it gives 4 different areas to look at with a lymph node to help determine benign versus malignant. Does the needle size make it different? Bigger is better, more tissue, right? Well, for diagnosis, we don't see a difference in a few studies. What about using suction? No difference in yield. There may be some differences in amount of material, but no difference in yield. Now, how many passes do we take? Now, I'm going to follow this up on the next slide because this is an important part. There's a diagnostic plateau at 3 to 4. That's individual sticks into the lymph node. But that's not where you stop. And we'll talk about why in the next slide and also later in the discussion. And what about rows? Does rows make a difference? Well, studies show it doesn't change yield, but I can tell you I could not do what I do without Dr. Brainard because she helps me do less needle passes, sample less stations because she gives me an answer earlier. Also, I may not have to biopsy the mass or the nodule, so I'm putting the patient at less risk. We're not doing transbronchial biopsies, and it's a shorter procedure. So her role is invaluable in what we do, and I'll talk about some other reasons why her role is invaluable as well. Now, going to the number of passes. So how much tissue is enough? This was a study at using 85 adenocarcinoma specimens that were all diagnosed by EBUS-TBNA with rows. They looked at them for KRAS, EGFR, and ALK. not every molecular marker was included, but they found that an additional 4 passes was needed to get adequate molecular markers at around 95%. So the recommendation from that paper was do a minimum of 4 passes that are just for molecular markers. And that's key because we have some evidence now that we're not getting enough tissue in all situations. And I'm sure Gerard's going to comment on that later. The CHEST guidelines went along in a similar fashion that additional samples beyond those needed to establish a diagnosis should be obtained for molecular analysis. So keep that in mind. You want to get a lot of tissue. And I talked about the role of rows, and although it may not affect yield, it plays so many other important roles. But this has got to be a coordinated effort. There has to be communication between you and the people that are working with you. It's the bronchoscopist, the bronch-tech, the RT or the nurse, cytopath, the cytotech, the cytofellow. And this is regardless of rows being there or not, because they're going to work to how do we collect and how do we triage this specimen in the best way possible. We're smearing it appropriately so we're not causing any artifacts. And triaging decisions. Do we need to send this for flow? Does it have to go in RPMI? Should we send cultures? Making sure we have adequate tissue for immunohistochemical stains and molecular markers, just to make sure everything is handled appropriately. And then also that we're going to make sure we get good tissue for cell blocks and we routinely obtain those. All right, so now we're playing. What you're seeing here is obviously the EBUS needle going into the scope. We're going to take it down all the way, make sure the needle's in all the way, lock it and confirm that it's locked, and then we're going to set our peripheral sheet. We'll bring it back a little more here, which you'll see here. Now I'm adjusting that back a little bit more, getting that set. Once that's set, then basically we're ready to go live with our needle. So take off our safety. We're going to drop our lock here and we're going to identify our needle. We made our needle sharp by pulling the stylet back 1 millimeter. And we're going to identify our lymph node. There's our SVC. From the SVC, we're now going to tune in on this 4R lymph node. Lymph node's a little bit to the left side of the screen like it should be. You can see the green dot where the arrow's coming from, where the needle's coming from. Needle is in. We clean out our stylet. And once we clean out the stylet, we're going to start taking some samples. Suction is on, and again, suction, no suction, it's a little bit operator dependent. We're going to make some passes going from edge to edge. The often viable tissue is only seen on the cortex, so we want to make sure we include the cortex. I turned off the suction here basically just to demonstrate that with suction or without suction, it's the same process. Needle comes back until it clicks, we lock, we then release it from the working channel, hand it to our assistant. Now the assistant's going to take it onto the slide. Stylet in first, and we're going to use that to push out some sample. We just need a little bit of sample on the slide, and we're going to make 2 slides, as you can see here. We're going to smear, and then the rest of it will go into the satellite. I'm going to move on to the next slide here. Now, needles withdrawn from the scope, we place a small drop. We use this to make a smear. Once we've made a smear, 1 will get air dried, 1 goes into an alcohol fixative. Now, this one will then go on to a diff-quick stain, while this one will go on to the traditional pap stain. Now, if during our Rose evaluation we are positive for a carcinoma, then the remainder of our solution, of our samples, are going to go into cytolite, but also into formalin, looking for PD1, the PDL1. That will later get centrifuged and turned into a cell pellet. There's often a question of a smear versus a cell block versus a core needle. The size of the needle doesn't play a huge role. What we want to be sure about is that we get adequate tissue with all of these passes. Now, we've got the specimen that's in satellite. We make our cell pellet by spinning it, basically, and then we can form a thin prep slide or a cell block. The cell block will go on to immunohistochemistry, the thin prep for fish, and then we use our residual cell pellet to move on to get the other molecular markers, and we'll talk about those in detail later. As we're moving into that, we're going to talk about these molecular markers and the importance of targeted therapy. So do a little brief history, talk about these molecular markers, driver mutations, and checkpoint inhibitors as we go. So the history is we used to give systemic cytotoxic chemotherapy, and they killed cells that were growing and dividing, and they killed cells regardless. We've all seen patients that have had some of these untoward effects. But in some patients, we could see reduction of symptoms, improvement in quality of life, and even prolongation of survival. But that did come at a cost. Now, as we began as a group to understand molecular pathways and how they drove malignancy, we were able to identify oncogenic activation. And these were typically tyrosine kinases, not in all, but in some non-small cell lung cancers. These were identified as driver mutations. In the next slide, we'll talk about why. This began a paradigm shift. And we were able to develop specific molecular treatments. They would target these pathways, and this happened in the early 2000s. If we could target these pathways, we could kill malignant cells, but be innocuous to normal cells. And we were able to do this in both oral and IV forms. But what's important and what we want to stress here is the proportion of patients that have an advanced adenocarcinoma that receive guideline concordant tumor genetic testing still remains low. So we want to increase awareness because there are very important potential targetable genetic alterations that are found. And these driver mutations are part of it. So what is a driver mutation? Because fellows will often come to me and ask about this. It's the most useful biomarker to predict the efficacy of targeted therapy. They're genes that make proteins that are critical for growth and survival of the cells. They're not typically germline cells or non-cancer cells, and they're usually mutually exclusive. What I mean by that is you're not going to have more than one driver mutation other than 1 or 2% of the time. And these are transforming. So these are what initiates the evolution from non-cancer to cancer cells. And when they do this, they often impart this oncogene-addicted biology to the cell. What does that mean? Well, the protein causes a reliance in these cancer cells. So they have to get a signal from this driver to survive. Our normal cells have a switch. Sometimes it's on, sometimes it's off. There's a regulation with feedback inhibition loops or with some kind of stimulation. But oncogene-addicted cells, this switch is stuck in the on position, and they're no longer subject to any regulation. Now that's important because this reliance turns out to be their Achilles heel. So if I can regulate the signal from the driver downstream, this cell is unable to survive anymore. So if we can match a targeted drug to this driver mutation, we can kill these cells and improve our therapeutic efficacy. And we can often do that with decreased toxicity. And what you see on this graph is no treatment, and you can imagine poor survival, standard chemotherapy, better than no treatment, and then targeted therapy, which shows a marked improvement. And we'll get into a little more detail with that as we go. The NCCN does a great job in trying to educate folks, and about multiple times, but at least every year, they come up with reiterations. This is version 3 of this year that was done in February of this year. And they wanted to stress a few things. So if we're talking about adenocarcinomas, and this includes also large cell and non-small cell, not otherwise specified, they want to stress that molecular testing should include a multitude of molecular profiles. So we want to do EGFR, ALK, ROS, BRAF, NTRK, MET, and RET, but also include PD-L1 testing in all of these. Now they've also gone to say you should consider that molecular profile in the squamous cell situation, but also make sure we're getting PD-L1s in these patients. It's a busy slide, so just a few key points to summarize it. We want to make sure we can perform this extended gene panel with a little bit of tissue. And this is like the next generation sequencing. And again, we'll touch on that in a few. We want to be sure we've got adequate tissue. If we don't, we have to repeat a biopsy. PD-L1 testing should be performed in all cases of non-small cell lung cancer. And broad molecular profiling is key. It'll help us identify driver mutations that will send us to available drugs that will target them. And if not, direct us towards clinical trials. And again, patients with advanced non-small cells should have the tumor assessed for driver mutations. Now, how do we do it? There's not a single platform that exists. So if we're looking at a platform, we want to make sure they have a few features. It's got to be a fast turnaround time. They've got to be cost efficient. We should be able to perform it on the small samples, on what's clinically available. Some type of automation, so we don't have to have someone dedicated to running that test. Conserving the sample so that we don't have to use it all each time, and we can run other tests if needed. And then potentially these can be multiplexed, meaning we'll get multiple results from one single sample. And that's one thing that the next generation sequencing is fantastic at. And this is just a reiteration of what we talked about before. We have a resuspension in the preserved site. And that can go on for DNA extraction, amplification, and sequencing for things like our EGFR, or KRAS, or our next generation. We can make a cell block, as you see here, and that goes on for further testing. Or we can make a thin prep, which will go on for fish. Now let's talk a little bit about the molecular tests. So the DNA allele-specific testing is one of the earlier ones. It replaced one of the earliest, which was direct sequencing, and it's become a default test for a lot of EGFR testing at many centers. It's raw DNA that's amplified using PCR and has a really good sensitivity, especially with rare signals. It's been a big leap forward from direct sequencing. It can be multiplexed. It's faster and it's cheaper. But the problem is you can only use pre-specified targets. So I've got to know what I'm looking for, and then it can find it. But it can't find anything new or any emerging biomarkers. Next generation sequencing, everyone has heard about because it's been very hot in the lung cancer world. It overcomes a lot of the earlier shortcomings and is being adopted rapidly across our country and worldwide. It allows for a parallel approach. So there's an automation level. We get a quantitative analysis, especially on infrequent alleles, and we also get a simultaneous evaluation of multiple genes or even an entire genome. It has a fantastic sensitivity, even with a low tumor burden, and that's a big improvement over earlier testing. A sensitivity that's high enough even to use for blood-borne tests. It can also identify new abnormalities or emerging biomarkers, those that we can't test other ways. The disadvantage, though, is it does take effort, a dedicated individual who has a specific skill set. FISH is another commonly employed technique. It's a fluorescent probe, and it binds to specific nucleic acids. So it can detect gene rearrangements that we know about, translocations, amplifications, deletions, particularly useful in ALK and ROS. Next, we'll talk about immunohistochemistry. And that's sensitive, very specific, and also very good for ALK. It's rapid and reliable. The key with immunohistochemistry is it's the definitive method to look for PD-L1 staining, which we'll talk about later, and you'll see why it's so important. There are many types of oncogenic drivers, and again, this alphabet soup, as well as checkpoint inhibitors. Now, what I want to talk about here is initially we had non-small cell lung cancer as its cancer, and then we got a little more sophisticated. Well, it's adenocarcinoma, or it's squamous cell carcinoma, or it's something else. In those, we later were able to break down to a number of different mutations. And this was critical because we could target some mutations, but we couldn't target others. But now we have got more pieces of this pie. And this is not even the most up-to-date picture of the pie. Just know there is an enormous amount of mutations that we can detect and a potential enormous amount of areas that we can target and treat, like EGFR, or epidermal growth factor receptor. It's a tyrosine kinase, and it's present in 15% of non-small cell carcinoma, adenocarcinomas in the United States. It's a little more prevalent in non-smokers, and there's a high percentage in the Asian population. Now, in advanced non-small cell, it's really important because its presence confers a more favorable prognosis. So if we see this, we treat with a tyrosine kinase inhibitor, and we get a better response. With our first generation, second generation, and now third generation TKIs, we are seeing remarkable improvements. It used to be we would treat with the first generation, then move to a second generation, and then to a third generation if we developed the resistance. And that was something we could also identify as this T790M resistance. And we have a third generation now that will treat for it. This has become so good at treating, it's now even preferred as a first-line treatment in many cases. ALK, is another tyrosine kinase. This is seen in non-smokers and younger patients, again identified by FISH, IHC, and most NGS panels. And again, what's critical about this is we have treatments for this. We have multiple treatments, and these treatments prolong their progression-free survival, an 84% survival probability at 12 months. And then we can add a newer generation after that and prolong that survival even more. So what's critical about these is that we have targets to treat them, and targets that can treat them very well at this point. For instance, we've got ROS, another tyrosine kinase, present in 1 to 2% of the adenocarcinomas. Younger, never smokers, and again, what's key is we have treatments for it, treatments that confer a high response rate. NET is similar, another tyrosine kinase in 3% of adenocarcinomas. But again, approved therapy that will improve survival, as well as clinical trials with new ones along the way. RET is another tyrosine kinase in 1 to 2% of the population. And again, FDA-approved treatments that prolong survival. BRAF, same thing, 1 to 3%. And again, better prognosis with approved treatments available. And this is what we're trying to stress. NTRK fusion is also, it's a rare one, but we've got treatments for it, an oral inhibitor, and they're both FDA approved. HER2 is a little different. So it's a human epidermal growth factor receptor 2. It is in the family of tyrosine kinase receptors. It's in adenos, never smokers, and women. Now this, we may not have an on-label therapy, we have some off-label, but we see this, we want to encourage patients to look towards clinical trials. So again, a clinical reason to look for these. KRAS was also one that in the early days, if we had KRAS, we didn't look for the others because of that mutual exclusivity of driver mutations. 13% of non-small cells have it, and it's usually associated with smoking. It was thought previously that it was untargetable, but now we have a monotherapy that we can target with disease control, with objective response, with a low rate of toxic side effects. So benefits to looking for it. And then the last one we'll talk about is programmed cell death ligand, PD-1, PD-L1, PD-L2. This was one that I would hear PD-1 and PD-L1 kind of used interchangeably. It took a while till I got a good understanding of it. But basically, if you've got a PD-1 and PD-L1 interaction, those cells are not seen by our immune system. And there's a lot of cancer cells that have high PD-L1 and PD-L2 expression. So they bind to that PD-1 receptor, and they're basically hidden from our immune system, and that allows that cell to grow and prosper. If we can break that interaction, it's no longer hidden, and then our immune system can target it and kill it. So now we have the ability to target that. We block that interaction in lung adenos and squamous cells. And when we block that, we see an improvement in progression-free survival, in overall survival. And we have these antibodies here that are all approved for use today. And we're seeing dramatic effects from this. Now, one thing that we do see is when we've got more, and generally it's broken down in less than 1, 1 to 50, or more than 50. And this is an immunohistochemical stain of it. This is a high percentage of the PD-L1, and that will generally tell you you're going to have a good response. It's not perfect, but it's a good guidance to go. So now we have a prognostic reason, but also a clinical reason as far as how we can treat these patients and improve their survival. For the last few slides, I wanted to show you a couple of pictures, some CT scans. These are actual patients that we've treated here. This is February of 2019. This is a huge tumor burden here. April 2019, that's almost a normal CAT scan. A phenomenal response because we were able to identify a marker and treat it with the TKI. Same TKI, gefitinib. Look at the amount of tumor burden here. This is a huge tumor, and it went to this in 3 or 4 months. Phenomenal responses because we can target these markers. It's not just EGFR. ALK, we've seen the same kind of responses. Look at all of this tumor. This is a massive amount of tumor, multiple nodules, and lymphangitic involvement as well. And look at this response a couple months later. We're now looking at survival in years instead of weeks or months with many of these. Pembro in the Keynote trial is another one. This was a randomized phase 3 trial where they looked at Pembro versus a platinum doublet, which is a standard chemotherapy regimen. They found a 5-year overall survival rate was almost double what we would typically get. But more than that, if we completed 2 years of Pembro, we had a 5-year survival of 81% in that group. And that is phenomenal. And that's the reason we want to do this. Another one, the Pacific trial, this is using durvalumab. And this was an improvement in 4-year overall survival of almost 50%. We used to have a 5-year survival that was around 15% in most of these cases. So we're seeing great responses. But what I want to draw your attention to is down here, that we had a median overall survival of almost 48 months using durvalumab. That is just a phenomenal response. So why are we testing? We're testing because we can treat. We can see a profound improvement in survival, overall survival, progression-free survival, survival probability at 12 months. And this is done with a lower amount of adverse effects. And this is important because we now have a higher percentage of younger patients that are being treated. We want to get those patients moving forward and enjoying what's left of their lives. Coming back, concluding with the pulmonologist role, that's primarily how we're going to get tissue with EBUS. And EBUS is a cornerstone of staging for the mediastinum and lung cancer. We know those samples we get are effective for molecular analysis. We got to get adequate tissue, and that means we have to do multiple passes and communicate this with our cytologist pathologist. We want to make sure we order a broad molecular profile at the time of diagnosis. Whether it's triggered in some way, it's a reflex, and we'll talk about that in the next session. But we have targeted therapies and checkpoint inhibitors that show long-term survival. So the idea that advanced stage lung cancer is a death sentence needs to go away. We have effective treatments now. And how do we make all this happen? By keeping open lines of clear communication with pulmonary, with oncology, and with fantastic colleagues like Dr. Brainard. And that's what I've got, so thank you all. I'm going to stop sharing my slide here. We'll go back to this. Thank you all.
Thank you so much, Michael. That was a tremendous whirlwind talk. I forgot to mention to the group that you're also the best dressed pulmonologist that I know. Jen, I'm going to open it up to you. How many mistakes did Michael make in going through the pathways in pathology?
He did a great job. Great job. I didn't see any mistakes.
Is there something that you'd like to emphasize or share in the talk that he gave?
I mean, I think there's a couple practical points. I think Mike certainly stressed the communication that we need and talking and interacting with the people from cytology if you're able to have rows. One thing that Mike showed was the needle rinse solution. We use Cytolite at the Cleveland Clinic. Some people use formalin, other things. It's really important and very practical to look at what's in that rinse before leaving the room, because sometimes most of your specimen is on the glass slide and you may not have a lot of material left. So our bronchoscopy nurses are great at looking at the needle rinse and providing feedback to the pulmonologist that you don't have enough, particles floating in the rinse to be adequate. So I think you get pretty good at looking at your needle rinse grossly and seeing, oh yeah, I've got plenty of tissue in this specimen. This should work out fine. So that's one thing that if people are having trouble, that's a good thing to do. Ask your cytologist to take a look at the tube and see if he or she thinks that there's enough material in that. And if you don't have people on site for rows, take a look at the rinse yourself and make sure that you have particles floating around, because if you have that, you will have a much higher rate of getting diagnostic material that you can use for all the ancillary tests you need. If you don't see anything in that liquid, you're probably not going to have a great specimen. So that's one of the things I like to emphasize. But otherwise, I think Mike did a great job. I think we are blessed because our pulmonary colleagues know what we do. They've come to our lab, many of them, and asked a lot of questions about what we do. So I think that benefits all of us.
Jen, I'm going to push back just a little bit on one thing, and not really push back, but just sort of play devil's advocate, because I can tell you that I'm really close with our pathologist, and in watching Mike's lecture, I realized that we do some things differently. So, for example, we'll make extra slides, and then they'll look at the slide and then actually scrape the slide. So that's another technique. Can you just comment on whether there's more than one way to skin a cat? I worry that people online right now will be going, holy cow, the Cleveland Clinic does it this way. It's the only way we could do this. Cytolite's the only thing we can put it in. Yeah. I think Mike will tell you that Kazu Yasufuku, makes a clot out of his on a piece of paper. And so I know there's not just one way to do this. Can you tell me am I okay at the Medical University of South Carolina, or are we just flat wrong?
No, you guys are great. That is totally fine. You can get DNA and RNA for molecular testing out of many things, including scraping material off a glass slide. Very easily done. You get great quality DNA and RNA from doing that. You can rinse into formalin if you want. You can put everything in formalin. You can put it in other fixatives. There's other commercial fixatives that you can use. The key is really probably at the beginning, the working it out with your pathology colleagues of what you're going to do with the specimen and in what form do you need it to make sure you can have all these ancillary tests. No, that's an excellent point. And because these specimens are small, we really go to great lengths to maximize what's available for testing, and people do that for in different ways that work fine. I think it's more important the effort put into it at the beginning or periodically throughout to make sure that what you're doing is actually getting good results. So I think you have to put these procedures in place, and you have to evaluate them and make sure what you're doing is working. But there are plenty of other ways to do this.
So we just, I think I was talking to you guys before, and by the way, before I get to that, please, for our audience, please put questions and answers into the question and answer box or into the chat box so that we might answer any of your questions. We were talking about this before. We recently interviewed chest members, 453 chest members. And one of those things that came up was the variation in number of passes people make. And so I just want to re-discuss that with you, Michael, and a little bit with you, Jennifer, because I want to put a twist on it. So, Mike, you said, look, 3 to 4 passes, that's for diagnostics, right? And then some number of passes after that. It turns out in our survey that, first of all, 10% of the respondents only did between 0 and 3 passes per lymph node, which I thought was not good. And then a large number, I think 55%, did only 3 to 4 passes. And then, interventional pulmonologists such as yourself, did more than 7 passes, and that was about 15%, but largely the IP community. So with Rose on site I'm going to just give you our institution. As soon as my pathologist says, yes, you've got enough on slides, we then put an additional 4 passes into Cytolite. And by the way, if Rose is there and it's just one of these either one of 2 scenarios where there's not that much tumor on the slide, you have tumor, but there's not that much, they'll tell me to even get more. Or if the tumor looks pretty necrotic and they're not able to really make out the cells, they know it's cancer, but they'll ask me to give them more. So Michael, is that sort of what you do? As soon as Jen or one of her colleagues says, "Hey man, you got it." Yeah,
how many do you take afterward? One of the things that I also want to make sure that folks know is it was a really good study on that diagnostic yield, but it was only about 100 patients. So we can't make huge sweeping decisions based on that, but that's the literature that's out there. But having Jen and her colleagues there, once they tell me I've got something, then there's a couple questions that follow that. Is it a good sample? Is it a lot of cellularity on there? Because that helps guide what I'm going to do. Our standard is 4 passes, just like you, after we have confirmation. But if she's telling me, I've got a little focus here and a little focus there, I'm going to do more. And something that I think is also not appreciated enough about having Rose or having the ability to look at it yourself is on occasion, I'll go to a different lymph node, one that I know is bigger. So if I'm doing a staging and I sample a 7 millimeter contralateral lymph node and that's positive, but it's not a high cellularity, then I can go to 7 that is 4 centimeters and get bigger tissue with more cells. So we're going to increase our chances of getting that broad molecular profile.
Hey, Jen, what if I push back a little bit and say, hey, man, it's great that you're at Cleveland Clinic. You guys got all the cool stuff and you have a million cytology fellows who can go down there. You can send your minions down and collect those samples. You've got everything going on. But I'm in a little community hospital. I don't get Rose. Believe it or not, at our VA, 2 blocks from the Medical University of South Carolina, we don't have anybody coming to the procedures. What do you tell them then? How many passes should they take?
boy, I guess at that point, then I think you would need to use the clinical characteristics, right? The nodes that you think are positive, I would probably do, 6 or 7 passes. I would advise that up front on a node that you think is positive. I think that's what you can do. I also think that even at small places, it's sometimes possible to find a friend in pathology. And I know people do this a lot, where you can find an ally, somebody who understands what you need and what you're doing and why it's good for a patient. And you can sometimes parlay that into a Rose mini service if you want, or in selected cases, particularly difficult sticks or somebody who's had a failed bronch before or some other scenario. And then I think sometimes you can work up from there. You can say, oh, we got so much better tissue when X, Y, or Z happened. And sometimes you can affect some positive change and movement towards Rose. But yeah. And we can teach you to look at a slide if you want. I know that's somewhat controversial and many people don't maybe want to do it, but you can kind of tell when you have malignancy and act accordingly.
Jen, I couldn't agree with you more. And I've often joked around when I'm on the podium and said, hey, look, like, buy a cup of coffee, go to the basement of the hospital, because that seems to be where the pathologists hang out.
Yeah.
Find their office, give them that cup of coffee and sit down with them for a little while. Tell them how important this is. Let them come and see an EBUS, right?
Yes.
Like, let them come and see an EBUS so that they can then get the specimen in the at least in the material that they feel comfortable. The other thing I'd ask you in regards to that, in terms of that, is I've noticed now that there's more sort of video conferencing around this.
Yeah.
So if we can have a cytotech prepare the slide,
yes.
You could still say in your very comfy office, look, I see that microscope right there.
Yep.
And we can send it to you. Are you seeing
yes.
more of that with your colleagues around the country, or is that something,
Yes. And I would say that we're doing it here too. We're just not doing it in bronchs because they go so fast. There's sometimes multiple procedures and the passes come pretty quick. So there is a longer time for telecytology. That's what we call it. But there are really excellent technologies that are very quick for scanning and for basically beaming the slide to the pathologist by a cytotechnologist or by a nurse. I mean, we can train anybody who can prepare a slide can load the slide into the telecytology equipment. So Dr. Machuzak, he's very good at making slides and staining them. He's an expert stainer. So he could put them, he could scan the slide to us as well. And the technologies today allow us to drive the slide ourselves remotely. So we don't need a qualified driver like a cytotechnologist on site. We can drive the slide ourselves. So telecytology should, could alleviate a lot of the problems of not having rows.
Mike, care to add to that?
Yeah, I wanted to make, I think, 2 comments on that. So first, I have no delusion that I'm not in a fantastic place with resources that are not common. But when I got here, we didn't have rows. It was also when EBUS was starting. So, but what we did, and Jen can attest to this, is her office is probably about 3 blocks away from where we were doing our EBUS. And we start talking to her about the importance of it. And to her credit, she understood the benefit to the patients. She'd load a microscope and all her specimens on a cart and wheel it these 3 blocks into this little hovel of a hallway and sit there while we got samples and took them out to her. And then, again, to her credit, she convinced her department the value and what it played in patient care. Now, we also brought about information about less passes and no longer needing the need for transbronchial biopsies, not just in lung cancer, but in sarcoidosis and so on. And so that grew. But the other part I would add is that if you don't have rows, then I think you have to be a student of your own skills and know what you can do and what you can't do. And the only way you know that is by going back and critically reviewing, how did I do? And you got to be honest with yourself. If you're looking and your yield is 50%, there's something you're doing wrong. So you've got to change that and look at it in increments, in 3 or 6 month increments. But it takes an effort, but you got to go back and do it. When I first got here, I did the same thing. I went back over the first year and I knew exactly what all of my yields were for all those cases. And I went back and I reviewed some of those cases from the videos and figured out what was I doing good, what was I doing poorly.
That's really, really good advice. I'm gonna push along to another question. I'm looking to see if there was any chats here, but while I look, I want to talk a little bit about this turnaround time business. So Mike presented a slide which said, look, we'd like to have that turnaround in 1 to 2 weeks. I assume that Cleveland Clinic does in-house NGS testing. So, that works for them. What I'll tell you is that I recently looked at another survey I've worked on with members of ASCO, the American Society of Clinical Oncology, and I'm working with oncologists. And it turns out that there's a significant portion of oncologists who will start traditional therapy if they're not getting their mutational analysis back within a short period of time. And we know that that's not the right thing to do. We know that they should wait for that. And I think some of it's driven by patients who are very nervous during that time. Jennifer, can you tell us how we can decrease the turnaround time, both in a place like Cleveland Clinic where you have next-gen sequencing, but also if you have to send it out?
Yeah. I think the key is there's a couple keys. One, making sure up front that you know what to order, which is more convenient and rapid if it's done in a reflex manner. And signing out the case. So you have to review the slides and sign out the case so that you know what to send, what parts are the best to send, and how to send it. And then you have to get a laboratory, send it to a laboratory that publishes its turnaround time, and it is within guideline. I would say that most large commercial laboratories are probably doing just fine in the TAT, and that the lag is from when the cases get sent out of your department. And so I would say reflex testing, so the pathologist knows what to order up front and isn't waiting for, sometimes, unfortunately, at some places, the pathology department will wait for an oncologist to order on after, and sometimes that's not immediate. That could be weeks, depending on, when the patient is scheduled and all that stuff. So, pathologists in general have a hard time with reflex testing because there's kind of an overwhelm, like a specter of self-referral. So there's a lot of pathologists in the past who have gotten in trouble for reflex testing that they've decided on their own to do. And so it's kind of looked at as, in some places, people are reluctant to do it because they will think that, I'm going to be in trouble for a fraudulent activity or something. That is really not the case. All that has to be done to allow for easy reflex testing is the pulmonology or the oncology department needs to have on record, which at the Cleveland Clinic is via a letter saying that we would like reflex testing for X, Y, and Z in this scenario. And so as long as the lab has something like that to show to an inspector, they're not going to, reflex testing is allowed and it's facilitated. It's much faster. And can get those cases sent out for testing quicker.
So
go ahead.
I don't mean to interrupt you, but this is such an important topic, Jen. And for our pulmonologists, they may not even understand what reflex testing is. And so I just want to make sure that we're all clear that reflex testing is something like this. I'm just going to give you the like this part. For pulmonologists would mean that when our specimen goes out, someone in pathology knows that if it's an advanced non-small cell lung cancer, we can talk about whether we'd reflex test stage 3A, 3B, 4, that in those patients who have a non-small cell lung cancer, we're going to, pathology is automatically directed to do the certain testing, test for PD-L1, test for ALK, and then do next-gen sequencing on the rest, and so that they don't have to wait. I think it's always been problematic, and again, in our survey of the 453 pulmonologists, about 30% said that 35% said that the oncologist ordered it. The problem with that is that we are the initial service that sees these patients, right? And so if it waits for us to see the patient, get a diagnosis, it's now sitting in the pathology lab. The patient gets an appointment with an oncologist 2 weeks later, and now the oncologist is going to order it. Now we're talking about another 2 weeks before it comes back. You're a month into an advanced lung cancer. What reflex testing does is it allows two things, I think, to happen. One is the speed, right? It leaves our lab, it gets to Jennifer or her compatriots. They know, okay, this is an advanced non-small cell lung cancer, it's an adenocarcinoma. This is what we're going to do with this specimen. So in the meantime, Michael and I have already referred our patients to oncologists, and while that referral is getting done and the patient's getting in, at the same time, they're getting this reflex testing done. The second thing I'd like you to comment on is, as it relates to this, is how do we keep up? I think pulmonologists, in my opinion, shouldn't be asked to keep up with the newest FDA-approved targets, right? So how often do you revisit? One of the good things about reflex testing is it takes into account all of the currently available FDA targets, right? But how often do you and Michael or some team sit down and say, hey, wait a second, man, New England Journal had 3 articles this week. FDA just gave approval of, for example, a new drug for even an earlier stage cancer, right? So now we're looking at new drugs for early stage lung cancer or the EGFR mutant patients. So tell me how often you revisit your reflex testing.
We revisit our reflex testing basically, like you say, whenever there's a new and actionable mutation, and that is usually, or a new discovery, and that is usually at the request of the pulmonary oncologist. So we have a working group, I would say, that is comprised of pulmonology, molecular pathology, pulmonary oncology, and site and pathology, and we revisit what we do, and we add things or change things with that group that really facilitates communication. One thing that's also important that many people don't know is that when you're doing next generation sequencing, you're getting a ton of data, but you may not necessarily be reporting all of that data. So sometimes when there is a new drug, you might already have the information in your panel. It just might not be on the report because heretofore wasn't targetable. So like for us, for our next gen sequencing, we do a 50 gene panel. That's pretty standard, or some places do a lot more than that. We don't report all 50 gene results, but when something new comes up, we kind of design those panels for things that we think might be in the pipeline for the future, as do all the other companies that are offering the same testing. So it might be a simple matter of data analysis and flipping a switch, and then you can get that result pretty quick. So next-gen sequencing opens up the ability to alter what's being reported with relative ease compared to methods that just looked at one thing. So I guess it's really important to have multidisciplinary communication as something comes up, or as at regular intervals, if that works. We do it mostly in the context of when something comes up. We'll change. I'm not sure how you do it at your place, Dr. Silvestri.
No, that's exactly right. And I mean, we do a 50 gene panel, same thing. And I think we're actually, if a new clinical trial comes up where they want that tested for, we add that to the panel if it's not already on there, et cetera. But yes, exactly that. And Mike, one of the things that's always impressed me is that how people like you and I live, eat, and breathe lung cancer and bronchoscopy as a general rule, but our colleagues in the community are seeing a bunch of COPD one day and have to keep up with meter dose inhalers for that, and a bunch of interstitial lung disease and pulmonary hypertension, and new drugs are coming out every day. You think it's as important for them to know that NTRK is a mutation that they need to know about it, or is it important just for them to know, hey, we got to test? We got to test in a reasonable time frame, and we have to get enough tissue. Would you be satisfied with our pulmonary community doing that? Or is it important that they know all the different mutations and biomarkers and new drugs that are out there?
No, absolutely. I think what I hope we got across in this talk is that we want to think about the idea that there is testing that's going to happen beyond, is it cancer and is it non-small cell or squamous? Is it adeno or squamous? And get tissue that is going to be processed appropriately. How that happens, I think if you got that reflex testing available, those are decisions that oncology is going to make in conversation with our cytology and pathology group. You need to know that it's part of it, but just having the idea that it's out there, that it's something that we should keep in the back of our minds as we're doing these procedures, I think is really what's critical. If I gave this talk next year, I'd have to add 10 or 15 more slides for whatever is going to be added on top of the markers or the checkpoint inhibitors that are presently available.
I couldn't agree with you more. And as I close, I always like to bring it back to the patient before I thank you both. And the way to bring this back to the patient is, for me, I honestly don't care if the pulmonologists know about NTRK. However, I would say this: even though it's a 1% find in a patient, for that single patient, it may be the home run ball, right? Like when you have cancer, you're trying to hit the home run ball. And if you have one of these 10 mutations that are in that 1% to 2% range, right? But with that, it's the home run ball. You got to go for it. And to not be tested for that, to me, is a sin. We need to make sure that we're communicating with our pathologists and our oncologists, that, we trust that they know what to test for and they know what drugs to give. But we've got to give them enough tissue. That's our obligation, is to give them enough tissue and communicate with them so that we give patients the chance to hit the home run ball. And with that, Michael, you want to add something
on that, Gerard? It's like you said, for that one patient, that's huge. But it's 1% for that one. It's 1% to 3% for another. It's 2% for another, 15% for another, 13% for another. So if we combine those, we're looking at a pretty substantial group of patients that we can be helping, but only if we're thinking about it and only if we're moving forward in a proactive manner.
Absolutely. And with that, I'd really like to thank both of you for a wonderful, wonderful chat. And I appreciate you doing this. And I appreciate Chest for doing this, as well as AZ for supporting this. Thank you so much.
Thank you very much.
Well,
take care.
Bye-bye.
Bye-bye.